Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone, in this beautiful, peaceful Friday morning. And welcome back to our day 2 of the 6th Conference of Saudi Osteoporosis Society. Our first session for this morning and number 5 session in the conference will be about updated guidelines and treatment threshold. Just a reminder, if you have any question, you can text to this number on the screen. Let me introduce you to our first speaker, our distinguished speaker this morning, Prof. Yusuf Al-Saleh. He is a professor of medicine and endocrinology, King Saud bin Abdulaziz University of Health Science, and member of the International Osteoporosis Federation Board, member of Saudi Osteoporosis Society Board. He will be presenting key aspect of Saudi Osteoporosis Guideline 2023. Please join me in welcoming Prof. Saleh to the floor. Doctor, you can start. The floor is yours.
Thank you very much. Thank you very much. Assalamu alaikum wa rahmatullah. Good morning, everybody. Thank you all for coming on a Friday morning. I know it's a bit difficult, but it's not impossible. And my task this morning is to address the updated guidelines for the Saudi Osteoporosis Society, and I'll take this chance to present on some key aspects of how to manage a patient with osteoporosis. So I'll try to address here in this presentation colleagues from family medicine and internal medicine generally, and I hope that you get some important points on how to approach a patient. I have no disclosures related to this presentation. Now, this is our 2015 guidelines, and I wonder if you had a look on them. They've been there since that time, published in the Annals of Saudi Medicine. And in these guidelines, these are the first to be country-level guidelines. We had, before that, King Faisal Specialist Hospital publishing guidelines before this one, and this has been a teamwork that involved many people, many colleagues from the Saudi Osteoporosis Society and from outside the society, many disciplines, so endocrinology, orthopedic surgery, rheumatology, and even biochemistry and pharmacology. And in these guidelines, we addressed several points related to how to diagnose and how to screen, how to investigate, and how to manage a patient with osteoporosis. Now, the guidelines, as I mentioned, are there since 2015, and now we are in 2023. So it's time to get them updated because there is new evidence that came out, and we wanted to address these. So this is the task force from the mainly members of the board member of the Saudi Osteoporosis Society, and again many contributing universities and hospitals and even private sectors are available between the members of the task force. They have been endorsed. So this is the updated guidelines, and by the way, they are not yet published, so it has been sent for publication. We got just a few weeks ago a few comments, and now resubmitted, will be resubmitted either today or tomorrow. So we'll see them published hopefully in the coming few weeks. They've been endorsed by the committee of the national societies of the International Osteoporosis Foundation. We are going to send it for also endorsement by the Saudi Health Council, representing Ministry of Health, and already endorsed by the Saudi Rheumatology Society. So this is the introduction on the new update for our guidelines. And this summary is relevant to all healthcare professionals in the kingdom involved in the care of patients with osteoporosis and osteoporosis-related fractures. We used and we looked at different references for the guidelines. So one of the major references we looked at are the American Association of Clinical Endocrinology. The name has changed. This is published in 2020. We also looked at the European guidance for the diagnosis and management of osteoporosis in postmenopausal women, chaired or first author is John Canis, who was the founder of the FRAX, for example. Cyrus Cooper, the president of the current president of ISQ or IOF, and many other international figures. We also utilized the GCC consensus reports. This has been published in 2020 again, and this involved the Gulf countries. So the co-authors are coming from all the Gulf countries, and in collaboration with the European Society for the Clinical and Economic Aspects of Osteoporosis and Osteoarthritis, ISQ. So all of these important references are there. And also we wanted to mention in the new update the FRAX, the Saudi FRAX. So the FRAX paper was published in 2021, and in this study, which is a huge work really, that took us almost 2 years to look at the incidence of hip fractures in the kingdom, and coming up with the Saudi FRAX. So, and then also we looked at this paper by Nasr al-Daghiri on the application of FRAX, how to use FRAX. So the outline of this update looks at various points. So I'll mention only the major points about the update. So screening, diagnosis, FRAX, the intervention threshold, management, and summary at the end. So a very important question when we look at our patients in family medicine and internal medicine, orthopedic, whatever specialty you're practicing, is to when to do a DEXA scanning, when to screen for osteoporosis. So let us look first at two important international societies, like the International Society for Clinical Densitometry and the American Association of Clinical Endocrinology. They advocate universal bone screening densitometry for all women 65 years and above. Younger than 65, they must have risk factors, and we'll talk about this. Or either they have a fracture, fragility fracture, not any fracture, or they are on osteoporosis medications or going to start osteoporosis medication. In our guidelines in 2015, we advocated screening BMD at the age of 60 years. Now this has been based on expert opinion, and at that time we did not have the hip fracture data in the kingdom. So this is going to be changed. In Kuwait, for example, their guidance, so they published or they distributed a paper, is not published guidelines in a journal, but one page or 2 pages where they recommended screening on those 50 years and above if they have risk factors. So targeted screening. And probably this is what we need to approach. So when a patient comes to you in the clinic, this is the National Osteoporosis Foundation guideline group in 2008, and this is what we adopted in the new update. So when somebody enters your clinic, you do FRAX for that patient before doing bone mineral density. And we'll talk about FRAX, how to do it. So we'll try to simplify this as much as possible. So if the FRAX score is high, you'll treat the patient. If it's intermediate, then you do BMD. And then add the BMD in the FRAX and see what is the reading. High, treat, low, observe. If it's the FRAX scoring when the patient enters your clinic is low, you don't need to do BMD. So this is probably the best approach. How to diagnose osteoporosis based on BMD T-score. So you decided to do in the intermediate risk or high risk patient. By the way, this NOF says high, treat without BMD. So some people say 70 years and fracture, treat them without BMD. But we always recommend doing a BMD in high-risk patients, mainly for baseline. And then you treat the patient and follow the BMD. And I will mention what is the interval of follow-up. So high and intermediate risk, do BMD. Low-risk patients or low-risk persons entering your clinic asking for BMD, you tell the patient that you are low risk. There is no need to do a BMD. And this is from economic point of view and from also evidence point of view, there is no need to screen everybody with bone mineral density. Now we see some people do BMD for premenopausal women. And that's again is a bit really problematic. Just a few weeks ago, I've seen a patient who was 35 years. Somebody did a BMD on her and her readings are low. Then what you're going to do for her? Are you going to treat her for 20 years ahead or what? And when you look at her risk factors, there is nothing there. So we'll talk about treatment based on BMD. So this is minus 2.5 on the BMD readings is a diagnostic threshold, not a therapeutic threshold. So this is to say this is a patient with osteoporosis. Premenopausal osteoporosis is a different category, and you have to be very careful to treat somebody who's young, even 50, 55 with T-score below minus 2.5. We'll mention this. Some people, they have a heel ultrasound machine, and this is used frequently in congresses, conferences, at the entrance of the Congress, and in the malls when we do, awareness campaigns and so on. And these are for screening purposes. They are not diagnostic. You cannot diagnose osteoporosis based on heel ultrasound. Now, is BMD enough? Back to the points. If you find somebody who minus 2.5, minus 2.7, which is young patient, do not treat based on that. So many people will say, okay, minus 2.8, osteoporosis medication. And the point about that is really important to say that what is BMD? It's a gradient of risk. So it expresses a gradient of risk, and it measures the standard deviation from a background population. What is our standard BMD in the kingdom? We don't have that. So whatever reading you get in the DEXA scanning machine that we have in the kingdom is based on the American software, and there is Lebanese software. So you're comparing our density in the kingdom to Americans or Lebanese. Lebanese is better. National Guard Hospital, where I used to practice, by the way, no longer there, we use the Lebanese software. But till this point, we don't have Saudi software. I hope that one day we get it. We have to screen large population of normal postmenopausal or a different age group, females and males, and then put that in our DEXA scans in order to make it as a reference background for our BMD readings. The absolute risk of hip fractures, for example, may vary up to 20-fold. We'll clarify this in the next slide or the one after. So it has suboptimal sensitivity and specificity. So the T-score of minus 2.7 is not specific and sensitive, and the ability to predict fracture is improved when you combine this BMD readings with other clinical risk factors. So this is what I meant by hip incidence of hip fractures across the world. We are in the low risk population in the green. If you look at here, Saudi Arabia, like Tunisia, Nigeria, and so on, at the bottom. We are not. So if we have a woman of minus 2.7, a Saudi woman, her risk of hip fracture is not like somebody from Sweden or Northern Europe or other countries in the red, in the upper part of this diagram. So countries are different in their risk of fractures, even at the same BMD or T-score readings. There are many causes for osteoporosis. So when you diagnose a patient with a T-score of minus 2.8 or minus 3, try to look at these diseases, different endocrine disorders, malabsorption, very important to rule out, autoimmune disorders like rheumatoid, systemic lupus, renal disease, and renal osteoporosis in CKD is a big category that is very complicated, and these patients should be referred to a specialist. There are many medications, but the most important are steroids, but also thyroid hormone over replacement. So these are all causes for secondary osteoporosis. So our task when you see a patient that comes in the clinic, you do FRAX, you find high risk, you do a T-score, BMD reading, you find a T-score, which is osteoporosis range, is to look at these diseases, try to rule them out clinically, look at the medications that the patient has, what is her past history, what are the concurrent diseases that she has, is she on thyroid hormone replacement, over replaced for a long period of time, malabsorption symptoms, and all of these secondary causes. Investigation-wise, what you need to do at baseline before starting treatment to rule out osteomalacia, vitamin D, calcium, phosphate, you do TSH, you do parathyroid hormone, look for primary hyperbara, for example, high calcium, high PTH, or normocalcemic hyperbara, so normal calcium but high PTH with normal vitamin D. If there is symptoms of malabsorption, then screen for celiac with tissue transglutaminase. We don't need to do all of these, but the basic things are the CBC, the ESR, TSH, vitamin D, calcium, phosphate. Some people advocate during 24 urine calcium to rule out hypercalciuria, which is an important cause for secondary osteoporosis. The third most important, or the third panel, which is most important, is the malabsorption. If there is high ESR, low hemoglobin, you do serum protein electrophoresis to rule out multiple myeloma. Two things that has been mentioned in yesterday's presentation, the trabecular bone score and vertebral fracture assessment. Again, before starting therapy, in the DEXA scan, if you ask them to do VFA, vertebral fracture assessment, this is done on the DEXA scan machine. So it shows you a picture like this one. And instead of doing X-ray, the VFA will show you the morphology of the spine, the vertebral spine. And this is, for example, a patient with T12 grade 2 wedge fracture, osteoporotic fracture. This might change the whole picture. So if somebody with this and he's osteopenic, not osteoporotic on T-score readings, you treat that patient. So osteopenia with fracture is osteoporosis. So TBS, again, that might enhance the diagnostic, sensitivity of the BMD readings. And again, this is a reading, so you can do the BMD and then see the readings or the risk for the patient, the FRAX score, all of them together to make your diagnosis more refined. Other indications to do the VFA, somebody has more than 4 centimeter height loss, kyphosis, recent or current long-term oral steroids, or a T-score minus 1.5 actually are additional indication to do VFA. So these are two modalities that will help in the diagnosis of the patient. Now, osteoporosis is very common, or number-wise, in the osteopenic range. Now, talking about FRAX, why people came up with FRAX, the fracture risk assessment? Because when the T-score drops on the right side, the percentage of patients who fracture is high with the low T-score, -3, -3.5. But if you look at number-wise, most of the patients are in the osteopenic range. And in this study, in the National Osteoporosis Risk Assessment, more than 200,000 women, the absolute risk goes up, but number-wise, more fractures happen in the osteopenia range. And to pick up these patients, people looked at these risk factors and came up with the FRAX. So this is another study which shows that fractures are very common in patients with no osteoporosis. They have other risk factors that makes them fracture. How to pick them up? You do the FRAX on the patient when he comes or she comes to the clinic. So BMD has limitation, as I mentioned, low sensitivity, does not explain the heterogeneity of fracture risk worldwide. So many countries have higher risk than our part of the world. And a T-score has a different significance at different ages. So T-score in somebody who's 50 is different from T-score with somebody who's 80 years. The 80 years have much more risk of fractures as a T-score of minus 2.7, for example, compared to somebody who's 50 or 55. And that's why it's very important not to treat except based on fracture risk assessment and taking consideration at VFA, look at for silent fractures, vertebral fractures, and rule out secondary causes. FRAX has limitations, and before going into these limitations, these are the risk factors that when the patient comes to you, you need to ask about. The age, so you put the sex, the weight, and height, so you put BMI, body mass index, based on these. You ask about smoking, alcohol intake, prior history of fractures, mother or father with fracture, parental hip fractures, and look for secondary causes, the points that I mentioned on secondary causes, steroid use, and the presence or absence of rheumatoid arthritis. FRAX performs very well in epidemiological studies. This is the Manitoba BMD registry in Canada, and they did FRAX for the patient, and they looked at what happens in reality. So they go hand in hand. So FRAX predicts fracture very well, whether in men or in women, the upper panel in women, the lower panel in men. And if you look at what is observed and what is expected from FRAX, so it predicts fracture very beautifully. So as we mentioned in the beginning, that Saudi Arabia joined the FRAX in October 21, and this is John Canis, the father of FRAX, as I mentioned. And these are the countries in the Middle East. So when you open the FRAX, just write FRAX in Google. The Google will open to you the site, and it's free. You press on calculation tool, and then Middle East, Africa. You press Saudi Arabia, and then another point, a picture will, or opening a page will open. So you fill this. You put the weight and height and the age and the sex. Rheumatoid arthritis, yes or no, smoking, alcohol, and then secondary causes based on the labs that you did. If there is any secondary cause, you put yes. And then you put the T-score. Another opening will open to you. So you put the T-score in either two formats, the T-score minus 2.7, minus 2.5, or the bone mineral content per gram per centimeter. And you press calculate, and it gives you the 10-year probability of fracture. It's just like the cardiology, what they use to predict future myocardial infarction. So this gives you the 10-year probability of major osteoporotic fracture and 10-year probability of hip fractures. This is the paper that we published with the group, and as I mentioned, huge work by colleagues from Ministry of Health and the Saudi Osteoporosis Society with the sponsor from Eli Lilly. The 10-year probability, this is comparing patients who have the probability of major osteoporotic fracture in Saudi women by age and comparing them to normal control. So the solid line shows probability in Saudi women with no clinical risk factors. The dotted line showed the probability in women with a prior fragility fracture. And the BMI is set at 25 kgs. So those with risk factors have a higher risk of fractures as has been expected. This is comparing our Saudi FRAX with countries like Kuwait, Abu Dhabi, and Qatar, and the Saudi Arabia and yellow. So the Gulf countries, more or less, they behave the same, except, for example, in Abu Dhabi in red, when they exceed at the age of 80, there is this drop. And we had the same thing, by the way, at the age of 80 and above. Actually, in 75 years and above Saudi women, we have this drop. And yesterday I was talking to Dr. Salwa that when you do FRAX in somebody who already had a fracture, a Saudi woman with fracture, using the Saudi FRAX, you might find low readings. And this is because of this. The mortality data in the kingdom just behaves like Abu Dhabi, so the risk drops in those who are elder than 75 years of age. So always, with any guidelines, we mention that use your judgment, 2 minutes, that's very short time. In clinical judgment, so somebody who had fragility fracture needs treatment irrespective of the FRAX readings that you're going to see. So prediction of Saudi FRAX is very good for younger people. And mind you that our data, when we collected the incidence of hip fracture in the kingdom, were not very complete. We just selected 15 hospitals across the kingdom, and our data are not that perfect, but at least we have something. Look for this example. So somebody who's 65 years with a BMD of minus 2.5, previous fracture. So we put the FRAX data, no fractures. She has a family history of hip fracture, no smoking, not on steroid, no rheumatoid arthritis, no secondary osteoporosis, no alcohol, and the physical exam BMI 24, and the BMD we put in the FRAX calculation minus 2.5. So we use this and look at the risk that FRAX came up with, 11%. We generally recommend a major osteoporotic fracture threshold between 8 and 10 in the kingdom. It's not like the United States, 20, and hip fractures around 3. So this patient with this history, this is just an example, with these risk factors of age, the family history, and the T-score of minus 2.5 deserve treatment. If you change the age on this patient and do FRAX, you will find a raw reading. So 50 years of age, the major osteoporosis fracture risk will be low. So it predicts beautifully the risk of fractures in the younger population. So whom to treat? Anybody with fracture, anybody with high major osteoporosis or hip fracture risk in calculating FRAX, and do not treat based on the T-score alone. I need to close quickly. So in the updated guidelines, I'm not going to go into details of this, but you'll find this figure where you plot the FRAX score of the patient and you put it in this graph, and you see if the patient is in the green zone, the intermediate zone, and the red zone. You do this before doing BMD. And then if the patient falls in the orange region, then that's the patient that you'll do BMD. And this is above this line in the middle, in the orange part. So if the patient falls there, you might need to do BMD to refine the T-score or the FRAX calculation. This is again the intervention threshold based on the age of the patient that you see. So you do FRAX, you look at this table, and you can find the threshold when to treat patients. So how to manage the patient, lifestyle modification, vitamin D and calcium, very important. And if you want details on vitamin D replacement, we have this publication back in 2017. So vitamin D status correction in Saudi Arabia, an expert consensus with the SQ by Nasr al-Daghri, but also all colleagues in the society were involved, and many from outside the Saudi Osteoporosis Society. Also, there's GCC vitamin D consensus report published in 2019. And again, this details how to approach a patient with vitamin D deficiency and how to replace them. These are the medications approved by the Saudi FDA to treat osteoporosis. Every patient is different from another. So there is nothing that fits all. You have to decide what is the best therapy for the patient in front of you. So some patients will do well on alendronate oral. I'll close in a few minutes. Denosumab is an injection, so 60 milligram every 6 months, and the duration is unlimited. Alendronate, be careful, 5 years, and you have to stop the treatment based on the repeat BMD. The repeat BMD we'll mention in a minute when to do it. Raloxifene is failing out of practice. Romosozumab, I think there are presentations on these anti-resorptive and anabolic therapy, when to use them. And there is zoledronic acid, once a year infusion. We have Pontio, which is the biosimilar for teriparatide. This is another anabolic agent. So we have 2 anabolic, teriparatide and romosozumab, and we have 3 or 4 anti-resorptive, alendronate, denosumab, raloxifene, and zoledronic acid. The updated guidelines will have the category when to use which. So it guides you what is the best therapy for each category of patients. So if they are severe osteoporosis, better to go with anabolic first. And these are the vertebral fracture effect of these medications. So anti-resorptive mainly act on the vertebral body, on the vertebral fracture reduction, but also they are effective to reduce hip fractures. So this table is going to be present in the 2023 Saudi Osteoporosis Society's updated guidelines. This is related to anabolic fist. So patient with multiple fractures, those with acute fractures, so they fracture within a couple of months and they come to you in the clinic, better to start anabolic for 1 to 2 years, romosozumab 1 year, teriparatide 2 years, and then you follow the patient with anti-resorptive. So you cannot use romosozumab or teriparatide and then stop without putting the patient on anti-resorptive, so to maintain whatever bone densitometry that you gained with anabolic therapy. This table is available there in the updated guidelines, so it tells you on diagnosis, fracture risk assessment, supportive treatment, the risk factor, and then additional information on osteoporosis, how to approach the bone turnover markers. And there is a section on this. There is a section on the follow-up of the patient, pharmacological treatment. So this is the intervention threshold, the graphs that we talked about, and then the follow-up of the patient. So the summary of the key recommendations for 2023 guidelines, diagnosis is based on diagnostic threshold is -2.5, but this is not a therapeutic threshold. So don't base your treatment based on the T-score alone. Look at all the other risk factors. Osteopenia, by the way, some people read osteopenia on the chart, on the report of the DICSA and treat, and that's not proper, always osteopenic. Look at the risk factor, do FRAX, and then decide on the management if they have high FRAX score. Fracture risk assessment, so we talked about this in a bit of details. So the summary will tell you about the TBS, VFA, and the FRAX model in the kingdom. And the general recommendation, counsel the patient and family, investigate for secondary causes, advice on increased sun exposure, advice on dietary vitamin D and calcium, advice on increased physical activity, and the treatment options that we talked about, the anti-resorptive and anabolic therapy, sequential treatment. This is anabolic first, and then you follow up the patient with anti-resorptive. Always try to do that, because if you start anti-resorptive in the beginning and then start anabolic, the effect is reduced with prior anti-resorptive treatment. So always anabolic first. Every treatment has recommendation for its duration of use and which patient to use. A drug holiday is not feasible with denosumab, so always when you start 6-monthly treatment with Prolia, you need to follow your treatment and never stop unless you put the patient on another anti-resorptive, if you have to do that. Monitoring, always the repeat of DICSA. We see some people do DICSA scanning on patient with osteoporosis in 6 months or 1 year. The best way is 2 years, and the minimum is 1.5. We always recommend the fracture liaison service, so somebody who will see who are the patient admitted in your hospital with hip or radial fractures or vertebral fractures, and these patients are commonly treated in the emergency or in the orthopedic ward and discharged without prior investigation. So there is a treatment gap in many institutions across the world, and definitely in the kingdom. And 3 papers published on this in the kingdom, one in National Guard, one by Dr. Muna in King Khalid University, and one by Sadat Ali in the Eastern Province. So preferably 2 years to treat patient, to follow up your DICSA scanning. Bone turnover markers are now present in some private sector labs, and you can use them to monitor the success of your anti-resorptive treatment and also anabolic. So 2 most important bone turnover markers, B1NP and CTX. So B1NP as anabolic monitoring, anabolic success of treatment, and CTX for anti-resorption treatment. The work in osteoporosis has been outlined by Professor Slimani in the introductory lecture in the kingdom. A lot of work has been done, but again, a lot of work is awaited. mainly the reference range for Saudi population is very important to be established. I know there are some data in the Ministry of Health, and I hope that they publish this or give us to us, we'll publish it for you. Always try to seek expert opinion if you are not sure on which patient to start treatment or what's the kind of treatment that you need to give your patient. Thank you for your attention.
Thank you, Prophet Saleh, for this great and interesting presentation. And now we're going to move to another session.